this morning is Hepatitis Treatment Innovations and Project ECHO from the Baylor College of Medicine. I've looked at the slides. I think you'll find this fascinating. We have a very brief we have no announcements, but a very brief reflection, which John, we are what we repeatedly do. Excellence then is not an act, but a habit. Aristotle. And I was thinking about that this morning. I was going to go back and look and see when Aristotle was born and when he lived. It's a long time ago. I thought this was pretty solid for all those years back. And it reminds me of the work that we've done in hypertension and in other areas where it's become a habit. And so I think there's a good message there. And we'll see that again today. So Tom, I'm going to turn this over to you to introduce our speakers and panelists.
Thanks, Gary. And again, appreciate folks showing up. And those of you who are listening to the tape, thank you for listening in. I think today's a great example of a lot of things. It's teamwork, it's community outreach, it's caring for vulnerable populations, it's tapping into our academic partnerships or any partnerships to just focus on caring for our community. So I'm excited about it. Let me just say a couple of words really quick about some of the issues in front of us. You know, I always think that COVID is going to be a boring story. Eventually, we're going to get tired of COVID, but it's still in front of us. We still have a lot of work to do in this space. And the one thing I'll tell you that we need to push hard for the vaccination, and we need to be the champions, the ambassadors of this, no matter what community we're in any way possible. Everyone that we work with and touch needs to be discussed about the vaccine and trying to get folks and listening to them and understanding their concerns and pushing them forward. So we have a lot of work to do. We have what's going to be a complicated fall coming our way with the colds and the flus and COVID. But I know we're going to be ready for it. Gary is preparing all the different groups to think about how to manage that situation as we go forward. So, all right, so let me turn it over to our speakers. I'm really excited about this. This is an area near and dear to my heart. I did a lot of research in hepatitis C in my Mount Sinai days, back in the horrible interferon days. But first up, we have Dr. Saira Khaderi, who's an assistant professor. She shook her head. I said her name right. I'm so excited. She's an assistant professor of medicine and surgery at the Baylor College of Medicine. She did her medical school at University of Texas. She did her residency in Cleveland Clinic in internal medicine, and then she did her transplant hepatology at Baylor College of Medicine. We also have joining us today, who'll join a panel, is Dr. Jose Luna. Did I get that right? Dr. Jose Luna, who is in a second act working and doing really amazing outreach in his community. He did his medical degree at the Medical School of Wisconsin, his residency in family medicine in New Mexico. He was the prior CEO of the primary care centers in Centro San Vicente in El Paso. And now he is working in outreach to very difficult to reach communities. Those who were previously incarcerated, those who are infected with hepatitis C, and really doing some heroic work and partnering with Dr. Khaderi. So I'm going to stop there. Way too much information on my side and hand it over to our speaker.
All right, thank you. Thank you for that introduction. Just get my slides on here. And thank you so much for inviting me to speak today. I just want to check to make sure that you can see my presentation. Yeah, okay, perfect. So I'll be speaking today about hepatitis C elimination, Project ECHO, and achieving those 2030 targets. So just briefly, what we'll go over is the detrimental effects of chronic Hep C, treatment of Hep C. We'll discuss how we get to that elimination of hepatitis C by 2030, which has been put in place by the World Health Organization. And we'll briefly talk about Project ECHO as well. So this shows you data that was published by one of my colleagues, Dr. Hashim El-Sarrag, and it looked at hepatitis C infected veterans over a period of 1996 to 2006. And what you can see is that the prevalence rates of cirrhosis, decompensated cirrhosis, and liver cancer steadily went up. This was the baby boomer population. These were patients who had acquired hepatitis C in the 70s and 80s. And as we know now that many of the newly infected patients are actually very young. This diagram or bar graph here compares patients who were cured of hepatitis C. So the blue, the SVR, sustained virologic response, means patients who were cured, and compared patients who were not cured of their hepatitis C. And so when you look at the rates of liver-related mortality, liver cancer, and liver failure, it makes sense that the patients who were cured of hepatitis C overall did much better. But it's not just about liver-related health, because what we can see is that the overall all-cause mortality also decreases as we treat these patients for Hep C. So unlike HIV and hepatitis B, Hep C can be cured. We have great medication for HIV and hepatitis B, which suppresses the virus, but there's really not a cure. What does a cure for hepatitis C mean? It means when you check the viral load about 12 weeks after treatment, that the viral load is undetected. Now, the patient is not protected from getting hepatitis C again. They can go out and get it again, but it's not a reoccurrence, it's a new infection. This diagram lists all the new medications that have come out in the past 10 years for hepatitis C. And as you can see, it's very complicated. And we used to spend about 20 minutes going over just this slide. But one of the best things about hepatitis C is that we've really narrowed it down to 3 medications. The first medication, sofosbuvir velpatasvir, we can use even in our sickest patients. The next one, glecaprevir and preventosvir, has a treatment duration as little as 8 weeks. And the third medication, which we actually don't need very often, which is triple therapy, sofosbuvir, velpatasvir, and voxilaprevir, these names are very complicated, as you can see, is actually used to treat patients who have failed the other DAAs or direct acting antivirals. This graph shows you the cure rates, or the SVR, for the different genotypes of hepatitis C. You can see that the cure rates are very good with these new medications, anywhere from 95 to 100% in most cases. Now, you may say there's no drug. I didn't list which drug this is referring to, and that's because all of the medicines really have great cure rates. And so this bar graph here is actually the Vosevi, the triple drug therapy that's used to treat the prior failures. So even in patients who failed hepatitis C before, we can get cure rates as good as 95 to 100% when we retreat them. Now, the World Health Organization has put a plan in for Hep C, or hepatitis elimination. What are the different targets that we need to eliminate hepatitis C by 2030? One is that we have to diagnose 90% of hepatitis C patients. And currently, worldwide, only about 20% are diagnosed. So that's the first issue we have here, is really finding those patients who have hepatitis C. Second is that 80% of the diagnosed patients need to be treated. And by the end of 2017, we only had 15% of patients successfully treated. And then third is we need to reduce the transmission by 90%. And these 3 things will help us get to that goal of elimination by 2030. Now, how do we achieve those goals? So first is we need effective treatment, which, as you can see in the slides that I showed you earlier, we already have. Great drugs that are very easy to tolerate, short durations, and very effective, 95 to 100% cure rates. Second is we need better allocation of resources. We need reduced cost of drugs and improved availability and affordability of validated tests. Some of you may remember when sofosbuvir first came out, it was $1,000 a pill. And even now with Mavyret, it's still the glecaprevir preventosvir is a $26,000 for an 8-week course. So we need to reduce the cost so we can treat more patients. We also can't forget about the testing that we need to diagnose hepatitis C. The screening tests generally can be pretty inexpensive, but the viral load that confirms the test can sometimes cost $300 to $400. Second is we need education and training of medical personnel to provide safe injections and prevention of cross-infection. This is not so much a problem in the United States, but in the developing countries, the #1 reason for transmission is in the medical clinics and laboratories and dentist office. Next, we need availability of health resources to socially marginalized groups, including people who inject drugs, prison populations, and low-income families. And I will be the first to say that when we started treating hepatitis C, or when I started treating hepatitis C, I did not treat people who injected drugs because in my mind, I felt like they were not going to take their medication like they were supposed to be, and that they would then go out and get reinfected. But what the data show, and I've made a completely different change, 180-degree turn, and we do treat patients who inject drugs, but the data show that these patients have cure rates just as much as those who don't inject drugs, and their recurrence rates are actually very low, less than 4%. So it's not about not treating these patients, it's about supporting them, and even clean needle and clean syringe programs. And then finally, inclusion of primary healthcare system is the front line for treating hepatitis C. So there are not enough hepatologists nor gastroenterologists to treat hepatitis C in this country or the world. So really what we need is my primary care colleagues to help us battle hepatitis C. And this is where Project ECHO comes in. So Project ECHO, ECHO stands for the Extension for Community Healthcare Outcomes. And the man that you see in the picture is Dr. Sanjeev Arora. In the early 2000s, Dr. Arora was the only hepatologist in the state of New Mexico. If you were a patient who had hepatitis C and you called to make an appointment, the wait time was somewhere between 4 to 6 months. And not only that, but because of the way that New Mexico is, you may have to drive anywhere from 2 to 6 hours to get to Albuquerque to see him. So what Dr. Arora found was that when the patients finally made it to their clinic, many of them already had cirrhosis, and some of them also had liver cancer. So what he did was he went throughout the state of New Mexico and started recruiting primary care clinicians who were interested in treating hepatitis C. Now, again, this was the interferon and ribavirin days where treatment was not very easy and it had a lot of side effects. But what he did was he set up these teleconferencing meetings where these clinicians would log on, present their patients, and he would then give advice on how to treat them. There were no patients that were actually on camera. It was similar to what we think of what we used to do when we round down patients and the other team members are presenting. So the program was a success, and they published their results in the New England Journal of Medicine in 2011. And what they found were that the patients who were treated in those local clinics through Project ECHO had the same cure rates as the patients who came to the University of New Mexico to be treated. And so there was no difference between university and community care. And not only that, but many of these providers had felt isolated because they lived in small towns. And now they had this connection to an academic center. So it was really about building this large community. So the concept of ECHO is actually very simple. People need access to specialty care for their complex health conditions, but there aren't enough specialists to treat everyone who needs care, especially in rural and underserved communities. So what ECHO does is it trains primary care clinicians to provide specialty care, and then patients get the right care in the right place at the right time. And this overall improves outcomes and reduces costs. Project ECHO is not really telemedicine. A lot of us have had experience, if we didn't before, with telemedicine in the past 18 months. And telemedicine usually is patient to provider or one-on-one. Sometimes we're directly speaking to the patient. Sometimes there is another provider involved, but it's usually one-to-one. But Project ECHO is more about telementoring. So one specialist, for example, myself, will train and discuss these cases with maybe 11 or 12, depending on the session, other providers who then go on to treat multiple patients in their own local clinics. So it's one-to-many, and it's a force multiplier. And an added benefit of Project ECHO is that we do provide we provide CME at no cost, which is very attractive to a lot of providers. This is what an ECHO session looks like. This picture in the middle is a little outdated. If I look 10 years younger, it's because I was 10 years younger. But this gives you an idea of what our ECHO clinics look like. So Project ECHO, again, is about getting care to people instead of getting people to care. So it's about moving knowledge, not people. And it's also about getting care to people who have no care. So this obviously is a map of Texas. You'll hear from Dr. Luna, who lives in El Paso, which is 670 miles away from Houston. So you can drive for 10 hours in Texas and still be in Texas. But one of the great things about ECHO is that distance does not matter. And although Dr. Luna is 675 miles away from us, he's one of our most active participants. And this shows you our, here at Baylor St. Luke's, we have about 60 ECHO partners, mostly in the southern states. And we've had over 2,000 case presentations. And you'll see the majority of the patients that are presented actually don't have insurance. And so these are patients that may never have received treatment for hepatitis C. But through Project ECHO, as well as the pharmaceutical companies who provide treatment at no cost to those that are not insured, we're able to successfully treat these patients. So next Wednesday is World Hepatitis Day, July 28th. World Hepatitis Day was put in place in 2010 by the World Health Organization to raise awareness about hepatitis. July 28th is the day that's picked because it's Dr. Bloomberg's birthday, and Dr. Bloomberg was the person who discovered a hepatitis B virus and then also created a vaccine for it. The motto for this year is hepatitis can't wait. And the reason for that, we all know how COVID has been so important in everyone's lives the past 18 months. But the thought is that hepatitis can't be put on the back burner. We have to continue our work with hepatitis along with COVID and everything else that's going along in the world so we can reach that 2030 elimination goal. And that is it.
Great. John, do you want to put us in? Great. Wow, thank you so much. That was a lot and just very concise and great work. Great work.
Thank you.
Jose, do you want to, Dr. Luna, do you want to jump in and just kick off, talk a little bit about how Project, maybe talk a little bit about maybe who you are, what you do, and then how Project ECHO has helped, your practice. And why don't you describe where you are and your patients and a little bit about your story?
Okay, first of all, I'd like to thank everybody, especially Dr. Khaderi, for asking me to participate. I am really honored. Like I said, my name is Jose. I am a family physician, and I've been practicing now for 38 years. I recently retired, and right before I retired, we created what's called a Center for Justice and Equity. Because I don't know if you know, but we are the other Catholic health system. We are associated with Ascension. So our particular focus is on the poor and the uninsured. And we found out that we have so many people coming out of our incarceration, so many people who are on IV drug users that, and nobody was taking care of them. So we decided that, to really create a Center for Justice and Equity, we had to address this. So we decided to embark ECHO. And I joined ECHO with Dr. Khaderi in Houston. And for the first, couple of months, I would just sit and listen. But now I think I am a seasoned hepatitis provider. I can treat, I would say about 95 to 99% of all hepatitis C cases with the help of Dr. Khaderi. She has taught us so much. And like she said, this is the ECHO model. Is you get together with your colleagues, and not only do you present patients, but you get to ask questions from the specialist. They answer the questions, and we answer questions among ourselves. We have grown so much through the ECHO model that here in El Paso, like she said, it's hundreds and hundreds of miles away from the epicenter of Texas, that we are the leading treatment center for hepatitis C here in El Paso. We actually get referrals from the medical center here in El Paso. We get referrals from the county health department. We see people from New Mexico. We see people from Juarez, Mexico across the border. We have successfully treated over almost 350 patients. We've done screenings for about 15,000 patients because our treatment is very focused. We have a high prevalence rate, which runs about 5 to 6%, believe it or not, because we are mostly screening people coming out of prison. And one thing that I want to tell whoever's on that treating hepatitis is, I would say, easier than treating a diabetic or a hypertensive. And I honestly mean that. I think you have more problems treating a diabetic than a hypertensive than you do treating a patient with hepatitis C. It has become so easy. The medications, even though they're hard to pronounce, that's what I tell people when I talk about it. They are so simple and easy. They're well tolerated. And I think for our center, it's been one of the most beneficial things Dr. Khaderi did talk about the high cost of the medications, but the pharmaceutical companies will provide the medications free of charge to those people who qualify. And since our clinic, we have about a 90% unfunded patient load, this is a godsend to our patients. So our patients get the treatment. It's I think the entire cost is something like $250 for the entire cost, including doctor visits, medications. So you can see, what $250 can actually save a life.
That's great. One of the questions, when you hear something like a 95% cure rate, which back when I was doing hepatitis C work, with interferon, these numbers were nothing like that. Just the eligibility to be on interferon was so difficult. It sounds like the issue now is not treatment; it's really it's navigation, right? So, I'm a big fan of navigation. When I was doing my work in Harlem, it was all about navigation and interferon therapy. Do you want to talk a little bit about, what are the things that we need to do to support patients to, one, get them into treatment, and then to keep them in treatment, and just make sure they go through this whole thing? What are the supports we need to have to make this happen? Because the treatment works, right? It works.
Yeah.
I don't know if you want to tackle that.
Yeah, and I'll let Dr. Luna chime in on that too. I was fortunate in that when I first started in hepatology, we were still using interferon and ribavirin. So I appreciate how difficult.
Back in the old days, back in my old days, back when I was,
Exactly.
Gary, they're
side
making
effects.
us feel old, Gary.
No, I was there too.
Oh,
I
you
promise.
were.
Yeah.
Okay.
And so, I think the one thing is we have to identify those patients who have hepatitis C. So in our clinics, we must do universal screening. That baby boomer population and that list that we had of patients who should get screened is no longer there. Everyone who is 18 years and older at one time should get checked. The other thing is a lot of our population, like we said, the newly infected, many of them are coming out of prison or people who inject drugs. And so if you do a test where you draw, or even homeless, if you draw a blood test and then you don't get the results for a couple of days, and then later on they have to come back for a viral load, it makes it very difficult to diagnose those patients and identify them. So point of care testing is very important so that you can make the diagnosis right then and there, and you can link the patient to care. So I think right now it's about identifying those patients,
Right.
And then linking them to clinics like Dr. Luna's clinic, Project ECHO, becoming a part of ECHO to get the treatment.
Let me just ask something. Just to keep and I'll come to Dr. Luna in a minute and ask Gary this question. I don't think that we're routinely screening Hep C on everyone. That would be. I sort of agree with you, but I think on a relative scale, we'd have to be more selective who we screen. Gary, I don't know. Gary, I can't hear you.
He's muted.
There we go.
Yeah.
I think we need to look at some populations and maybe even do some prevalence testing in our clinics to sort of see where we are. And so you guys do point of care hepatitis C, is that right?
Yes. If I can chime in.
Yeah, go ahead.
I think if you look at the CDC guidelines, they recommend screening everybody over the age of 18.
Mm-hmm.
Right now, we created what's called an opt-out model. Everybody gets tested. And they get not only tested for the antibody, but like Dr. Khaderi said, we reflex it. Any positive antibody gets automatically reflexed. Right. This will help us identify all the positive Hep C patients. It creates systems where a doctor doesn't even have to worry about ordering it. And if anybody is positive, they automatically come to the Hep C team. Because we have a Hep C team, it's not just me. We have nurse practitioners who are excellent providers, if not better care providers than I am. So you don't have to be a physician. Mid-level practitioners or advanced practice nurses can treat hepatitis C successfully. As a matter of fact, there is data that they do better than physicians. If Dr. Khaderi could maybe discuss that in terms of outcomes.
And it's the United States Preventive Services Task Force that changed their screening guidelines to 18 and above. And I'll tell you, if a patient comes to see me in clinic, the person that actually treats their hepatitis C is our APPs. We do the diagnosis, we determine treatment. And so they're very good. And sometimes I say they actually know how, when the kind of the lab schedule and everything a little bit better than I do, which by the way is minimal thanks to the new direct acting antivirals. So they are very successful in treating, very good at treating hepatitis C.
They've been in the forefront of this since the beginning. You know, in the work that I did, it was all APPs working on it, and they were really driving it in the primary care settings in particular. Well, even in hepatology clinics. Sorry, Gary, go ahead.
There's a comment here that says Allscripts has hepatitis C screening as part of our C preventive care recommendations. We follow Allscripts. We follow this in markets, but could certainly do better. And so I think there's
look at it. It's funny because my research was originally on screening, and I didn't realize that U.S. Preventive Task Force had upped it to everyone.
Yeah,
and is it? I was going to ask, is it once or is it every 5 years or?
So it's a one time for everyone 18 years and older. But you know, if someone has ongoing risk factors, then you would continue to check them. Now, the other thing I do want to mention is that, again, looking at those sort of the populations that are like the people who inject drugs, the low income or the homeless, like those patients we really need to take care of and continue to treat their hepatitis C. And like I said, for me, I would have been the first one maybe 6, 7, 8 years ago who would have turned especially the injection drug users away. But getting to that population of patients and treating them is critical because that's where the new hepatitis C is.
What about the dual? I mean, one of the things we had was the double infected, the HIV, Hep C infected folks. I mean, that was initially, you know, really where the challenge came. And Dr. Luna, are you treating the HIV, Hep C infected? And I'm going to throw one more thing: fiber scans. Are you guys using fiber scans?
So the FibroScan is a bit of a luxury in a lot of the clinics. And so FibroSure we use, and again, part of the clinic is we put together all the different blood work, the platelets, if there's an ultrasound to assess whether they have cirrhosis or not. But as you know, with the new drugs, sometimes the regimens are actually the same for cirrhotic or non-cirrhotic.
Got it.
And if I may, yes, I treat doubly infected patients, and they are, if following the guidelines, they are as easy as treating a mono-infected person. Just as the only caveat there that you have to absolutely make sure there is no drug interaction. And in terms of the fancy testing, our patients are uninsured. They have no insurance whatsoever. They're homeless. They're out in the street. They're IV drug addicts. They're coming out of prison. We do it based on the newest guidelines, and we do it based on clinical parameters. With the help of ECHO, we have been successful in treating the vast majority of our hepatitis C patients without all the fancy testings, the fibro scans, even the FibroSures, because that's an expensive test.
And what would you say, and I realize this is a different population, that your reinfection rate is?
So the data show that people who inject drugs, their reinfection rate is less than 4% per year. So, you know, I think a lot of us may have thought it would be much more, but again, Dr. Luna's clinic also has people there, I guess a therapist, and they teach them how to use clean needles when they go back out there, if they go back out there.
Okay. And one last question for me is, what is I realize that the pharmaceutical companies are providing this, but if they weren't, what would the cost per patient be for treatment?
So Mavyret which is, to my understanding, the least expensive medication, is $26,000 for a course. And remember, we started out with $90,000.
Yeah, I think it was $90,000 initially. Yeah.
So,
well, Gary, I guess we should wrap up.
Yes.
So I'll just say, and then I'll let Gary close out. You know, this is a great example of, you know, just reaching out to all the communities, using technology, expertise, community-based work. Dr. Luna, thank you so much. And Dr. Khaderi, thank you. Just great to see this. And also, I think you've taught us that we got to be screening for hepatitis C. We got to figure it out, Gary. And
yes, this is,
So, all right, Gary, I'll let you close out.
Sure. I just want to thank both of you and all the folks who are on this call. You know, as I kind of listen to this, and I sort of think about mission and Catholic healthcare, in a way, this is the hands of God reaching out there. I just think it's fabulous. So thank you so much.
Thank you for having us, and
Yes.
thank you for letting us talk about Project
Thanks to all of our panelists and all the folks who listened. We'll get this out and we'll send you the links as well. And I think this has really helped us, and we may be calling to enroll. So we really appreciate it. Thanks so much.